Okay, Brett went through a lot of the same kind of similar steps I think I do, and a lot of us do. We're going to talk about the challenging PAO. I'm just going to present a couple cases here and just kind of try to highlight some of the things we should be thinking about pre-op and then how we might deal with those intra-op. So what's a challenging PAO? A lot of different things kind of fit into that category. We can have severe dysplasia or an iatrogenic deformity of the pelvis that can be certainly challenging. The minor dysplasia or the borderline hip, as mentioned earlier, I think by Cecilia, that can be very challenging as well, as shown down here on the image on the left. That was a multifactorial instability that I did a PAO on that had a great outcome, but just a little challenging just trying to balance and know exactly where to put it. Certain patient characteristics can make things more difficult in terms of higher BMI, muscle mass, just the tone or the tightness of a patient, whether it's a large muscular male or a tight neuromuscular hip. Bone quality can be an issue in some of the patients, and then previous surgeries can certainly make things more challenging. So these are just some of the things that may make the PAO more challenging. So again, we'll present some cases, think about things we should be thinking about pre-op, and then how we may address them intra-op. So we've heard a lot of different preferences from different surgeons. I think we do a lot of things very similarly. Just real quick for me, I use arthroscopy in selective cases. The incision I use is on the right here. I used to use the traditional Smith-Peet that was described by the Gons group. I use incision along the lateral aspect of the iliac crest, off the crest about 1.5 centimeters, and then down into the hip crease. I do the ASIS osteotomy cuts you've heard about, and I use similar techniques. Reduction fixation we'll talk a little bit about. You've heard about that. I use fluoroscopy intraoperatively. Range of motion check for me, as we discussed earlier, is really important in assessing whether or not the hip needs an osteochondroplasty. I check for extra-articular impingement. We'll also take down the inferior spine, occasionally the anterior superior greater trochanter if we have extra-articular impingement. And then concurrent femoral osteotomy, surgical hip dislocation in selected cases. So reduction, I use a Chance pin placed between the inferior spine and the superior spine. There's a sulcus there with nice sclerotic bone, so I like to get the pin into that area. And then I use a large lobster claw clamp. And with this combination, I can do my full reduction in the vast majority of hips. Occasionally, for a huge reduction, I'll show you a couple other things I do. In terms of talking about the reduction, we use different terms. The terms I use for lateral coverage is adduction of the fracture or the fragment. Anterior coverage is extension or forward tilt. Anteversion is internal rotation. Retroversion is external rotation of the fragment. And then we've talked about medial translation, where we literally translate the acetabulum towards the midline of the body. In terms of assessing our reduction, we're looking at coverage of the femoral head. We're looking at inclination of the acetabulum. We're looking at congruency. We're looking at the anterior and posterior walls, the version of the acetabulum. We're looking at medial translation. For medial translation, we look at the distance between the inferior femoral head and the ilioischial line, comparing intra-op to pre-op. Jeff Neppel described that measurement that we use on every case. And then in terms of fixation, I use 4 or 5 screws as shown here from medial to lateral. And again, we assess hip flexion and inter-rotation to decide upon osteoplasty. So those are just some of the basic things in terms of how I do the operation in general. In the challenging cases, sometimes we have to change things a bit. Sometimes we have to compromise a little bit. So we'll just go through a couple examples. So this is a 15-year-old boy with severe dysplasia of the right hip, and you look at this hip and you think, okay, can we reconstruct this? Can we create a relatively congruent, stable joint? And that's what the goal is. For all our patients, we get an MR arthrogram, we get a low radiation dose 3D CT scan. Range of motion is a big part of the evaluation, both pre and intra-op. And in a case like this, we're thinking almost more like a salvage osteotomy to provide stability to the hip. Very likely, we're going to need a femoral osteotomy in addition to the acetabular osteotomy. So things to think about. This patient did not have neuromuscular disease, but in the neuromuscular patient with severe dysplasia, we certainly think about adduction and flexion contractures, which we may release during the procedure. If they've had previous surgery, scar tissue can make things more difficult. In terms of our osteotomy cuts, in this case, the ischial cut could be more difficult. It's going to be distal and medial because of the sublux superior nature of the femoral head. We very seldom release the rectus. We used to do that, but in a case like this, if you're having difficulty getting down to the ischium, that might help facilitate access to the ischium. The pubic cut, again, shouldn't be too big of a deal, but in the neuromuscular patients, sometimes the psoas is so tight that we do release the psoas. That is quite uncommon, but something that just to keep in mind in a real tight neuromuscular hip. In a hip like this, the hip is so high, we make a higher iliac cut. You don't want to get in a situation where you've cheated yourself in terms of the amount of bone you have between the acetabulum and your iliac osteotomy. So I would go more towards the blue line here above the anterior superior iliac spine, just to ensure that you have enough bone to work with above the acetabulum. Posterior column cut will be relatively standard, and as you've heard several times, in all hips we need to have a very free acetabulum. In a hip like this, it needs to be absolutely, completely free to do a reduction of this acetabulum. In terms of our reduction, it's going to be aggressive. These are things that I would add, so I usually use the Schanz pin with a lobster claw clamp, and that can take care of the reduction. In a case like this, if we need additional help, I'll put a pointed reduction clamp in the area of the iliopectineal eminence, and then a Hohmann I'll use to lever and push on the fragment to medialize it as we're doing our reduction maneuver. So those are just a couple more things you can do when you're doing a really aggressive correction to get it into position. And again, after we get our reduction, we're going to check things on fluoro, we're going to check our motion, and determine whether we need an osteoplasty or a proximal femoral osteotomy. So those are just a couple things to be thinking about in a hip like this. This case I did now probably about 15 years ago. You see acetabular correction. I think given this socket, this acetabular correction is good. I didn't feel like I could push the acetabulum anymore at the time of surgery, so we added a varus derotational proximal femoral osteotomy. Here he is at 10 years with a good outcome, slight occasional pain, a big golfer back to full activity. So a good outcome in a very severely dysplastic hip, addressing things on both sides of the joint, and really knowing going into it, you're going to have to do a very large acetabular correction and just be prepared for that. This is another case, severe retroversion. This is really a retroversion, severe retroversion of the hemipelvis, 15-year-old female with infantile hip infection, multiple surgeries, and now has developed right hip pain. So she has major retroversion of the whole hemipelvis and major retroversion of the acetabulum. You can see the overcoverage on the false profile on the right. And this is the CT, again showing that major anterior overcoverage on the left panel on the bottom here, and then on the right side you see the posterior insufficiency because of that retroversion looking from behind at the right hip. She also had a osteochondral lesion of the femoral head. We were concerned about instability of that lesion, so our plan was to treat the femoral head lesion as well as correct the acetabular deformity. So surgical dislocation with open reduction interfixation of this unstable osteochondral lesion, and then an anaversion PAO. So considerations, she's had multiple surgeries as a child because of the infection. She has scar tissue. Exposure is difficult. You just need to kind of focus on trying to identify normal anatomic landmarks. The rectus is helpful as you're approaching to make your ischial cut in terms of identifying the appropriate plane. In this case, we did the surgical dislocation first. We then did then we do the ischial cut. The ramus cut in this patient, very scarred down, so exposure of the ramus was just a little more work than usual. Important in this case, she's a very small female, so she's less than 100 pounds, thin. This is the kind of case where you could get too aggressive with your medial retraction as you're getting out to the pubis. So careful with the medial retraction because of the femoral nerve. And just basically, I would go subperiosteal out on the ramus just as far as you need to go and minimize that medial traction. Bring the leg up into flexion, adduction to relax the neurovascular structures. Again, kind of a tough ischial cut here. The pelvis is very deformed. We're going to have to get way medial and be careful because of the small size of the pelvis and the distortion of the pelvis. Again, flexion, adduction for a ramus cut. Standard ilium cut, posterior column cut. Very helpful in a case like this is to have a 3D CT scan. You can get a printed model to help better conceptualize the pelvis if that's helpful. And again, the acetabulum needs to be completely free to enable this pretty aggressive anteversion correction. In terms of our reduction, it's mostly going to be, so there's going to be major anteversion or internal rotation. When you do that, you tend to lose lateral coverage. So at the same time, I'm going to want to adduct the acetabular fragment so we don't lose our lateral coverage. So we want to maintain, maybe decrease lateral coverage a bit, but we want to do a major anteversion correction. On the bottom panel on the right, you can see with, this is a pretty big anteversion correction, but certainly in this type of correction or one that is bigger than this, we can worry a little bit about that anterior aspect of the acetabular fragment. So just superior to the inferior spine, you have this prominent bone, which we usually resect. But in a case like this, you may want to be more aggressive in resecting that bone because you can get nerve compression by that massive anteversion of the acetabulum. I know the burn group has reported on a couple cases, and we've had one case of a femoral nerve palsy with massive anteversion of the acetabulum. So we check that prominence and are aggressive about taking it down. And then when we do our soft tissue repair, we make sure we don't have too much tension on the tissues as we pull it over that displaced anterior acetabulum. Again, we're going to do our, obviously, intraoperative fluoro check, and this, I think here we did a very minor osteoplasty. So here she is, 7 years out with marked clinical improvement. We did the ORAF of the osteochondral fragment, and you can see we've got a nice correction of the acetabulum. We've turned this acetabulum into an anteverted acetabulum. She has good congruency, good coverage, little narrowing slightly there laterally, but this hip has been through a lot from childhood through now adolescence. Okay, so this is one I did this summer, and this, I think we're all familiar with this kind of case. This is a 20-year-old high-level collegiate basketball athlete. He's 6'6", he's muscular, he's tight, his bone is like concrete, and you're going into this case, you're just thinking, okay, this is going to be a lot of work. So the bony cuts are more difficult. The exposure is a little more difficult, so you don't skimp on your incision. You want to have plenty of room to do your work. The muscle tone about the hip makes it more difficult. So a lot of things making this more difficult. In terms of these hips, he's quite dysplastic and retroverted on the acetabular side, and then he has these remarkable femurs with no head neck offset and impingement as well. Hip flexion is 90, and then IRF is 0 bilaterally. So he really has a major impingement as well as a dysplasia. His femoral version was relatively normal. I think it was like between 10 and 15 degrees. So not a version issue on the femoral side. So big male, more work. Don't skimp on the incision. The psoas in these patients a little different than the small female. This is a big guy with huge muscles and a big tight psoas, but less of a concern in terms of medial retraction just because he, I think, self-protects when we make the ramus cut. We've heard about the lateral cortex here in the ischial cut. That's really important in a patient like this. That bone can be so hard that you literally can't cut it. So what I will do is I make 3 cuts, a medial cut, a central cut, and a lateral cut. In a patient like this, if I can't complete the lateral cut, then I kind of take a break, go do my other cuts. A lot of times after you make the posterior column cut, you can come back and then that bridge of lateral cortex is not as thick and it can be cut at that point. So I'll go do the posterior column cut and then return and make a final lateral cortex cut. The ilium cut in these really big male patients, the ilium as you get towards the pelvic brim and the superior aspect of the posterior column can be very wide. So you just need to be aware of that. You're thinking, am I really still in bone? And yes, you are. They can just be very wide in that area. So be aware of that. Okay, and again, we need the real free acetabulum. So again, this hip, we want anteversion, we want lateral coverage, we want to translate the acetabulum medially. So we want to maintain that lateral coverage with adduction as we antevert. Don't overcorrect. This guy has instability and impingement. He's prone to impingement, so we don't want to overcorrect things. He's definitely going to need an osteoplasty, and then we're going to check the inferior spine, which is another source of impingement in this type of patient. This is how I go after that real thick bone of the ilium as we go towards the pelvic brim. Just use a 1/2 inch angled osteotome to complete that if need be. So here he is. So he's 3 months. In the high-level athlete, I'll stage him by a month just because they want to get back, and we can do that. So I'll stage him a month apart. So he had bilateral PAOs, bilateral head neck osteochondroplasty through the arthrotomy, did not scope these hips. So happy with the corrections. Tried to purposely maybe cover him a little less in front because of his being prone to impingement. But happy with the corrections and the healing, so we'll see how he does. Okay, final case. I just show this because of some of these patients, the neuromuscular patients, patients that have had previous surgery, their bone quality can really be challenging. And in the young patient, they can have poor bone quality, strong periosteum, and it really can be a challenge to move the fragment in that setting where you don't have a great bone quality of the acetabulum. So you got to be careful about that. So 32-year-old female, she had a previous triple osteotomy. She has a deformity of the hemipelvis here. She's uncovered anteriorly, laterally. She's had a shelf procedure as well. So somewhat of a complex surgery. Again, I did this several years ago. Today, we may think about a total hip in this patient. One thing about her, she had very poor abductor function from her childhood hip surgery. So important to note that. Know how that is going to impact her outcome. I think we can give her pain relief, but in terms of function and limp, maybe not get a perfect hip out of this, and she needs to be aware of that. So similar issues, scar tissue, the abductor issue for her is important. We have this triple osteotomy deformity. We're going to want to get a CT scan to better understand that. And with poor bone quality, again, the socket needs to be completely free, and you want to make sure it is before you try to do your reduction. I'll use a larger Schanz pin in these hips with poor bone quality, so a 6.5 Schanz pin just to get that initial fixation of the fragment for our reorientation. And then special about this case was just taking down the shelf anteriorly after the PAO. So here she is, 10 years. She has done well. She has a good result. We did provide pain relief. She continues to have abductor dysfunction and a limp, but certainly has been worthwhile for her. Okay, so powerful treatment for challenging hip deformities. You've seen a lot of this with the different talks today, and a lot of good tips, I think, a lot of similarities in terms of how we do things and what we are concerned about when we're going into a more challenging case. So as you think through the case, think about your exposure, think about the soft tissue characteristics of the patient that may impact your procedure, think about your osteotomy cuts, what may be challenging, what may be different. Think about your reduction and specifically how you're going to do that and whether or not you need a little extra instrumentation to do that. Think about your fixation, obviously, and then other procedures anticipate ahead of time so you're prepared to do those if needed. Thanks for your attention.